A lot of recent literature is supporting that we can be using these smaller chest tubes like a pigtail for trauma patients, even those who have hemothoraces. And these can be utilized for typically stable trauma patients, and especially those that only have something, say, like a pneumothorax.
Hmm.
They're smaller, they can be a lot easier to put in, and they're a lot less painful for patients as well.
Yeah, and they're also pretty much simpler to take out as well, right? So walk us through the kit. What do you have here?
So what we have here is we have a 14 French pigtail chest tube right here.
Yep, so I'm going to take that. You can see kind of the pigtail to it.
And you can also see here there's fenestrations along the edge of it as well. And these need to be in the chest cavity to make sure that it's able to hold suction. What you also have with that is you're also going to have the trocar as well, which will help guide the chest tube into the chest cavity.
So it shows how that goes together.
So what you'll do, in order to give it some rigidity and allow it to get through the chest wall, it'll basically give you means to introduce it safely into the chest wall and straighten out that pigtail aspect of the catheter.
One of the pitfalls I see is some people actually pop the three-way stopcock off and try to fit this. That doesn't work, right?
No, and it was always going to be dependent on the type of kit that you have. For the one that we see here, this kit is designed to actually have the three-way stopcock on it while you introduce the trocar.
Awesome. What else do we have in the kit?
So the other things that we have is hopefully stuff that you guys are going to all be familiar with if you do any other procedures with a Seldinger technique, and that's going to be some needles that you'll use to get into the chest cavity. You'll then also have some type of scalpel in order to dilate the space, and then we also have a dilator as well, and this is going to further dilate the space in the subcutaneous tissue in order to introduce the pigtail. We also have a few other things in here like the connector for the pigtail that can then go to the pleurax right here. And last but not least, this is something that you can put on that's optional. I don't know if you do this, Sean, but I typically don't put on the Heimlich valve, but it is a nice one-way valve.
Mm-hmm.
You just don't want to put it on the other way because then that can actually cause a reaccumulation of air, which we don't want.
Fantastic. And then obviously you've got your wire, which is standard for any Seldinger procedure.
Absolutely.
All right, let's move over to our mannequin here. Can you tell us a little bit about where we're actually going to be putting these chest tubes?
Yeah, so we typically want to put the chest tube in our triangle of safety, and a lot of times I'll place these in an anterior mid-axillary fashion. If you look at the mannequins, the typical teaching is going to be at least above the fifth intercostal space. Usually I'll do, my landmarks are from the nipple and following the curvature of the rib down. And we don't want to go beyond the lat. This is going to be the mid-axillary line. And then also the pec as well, which will define not going anywhere above that because we can run into great vessels by the clavicle up here. So on our mannequin, typically down from the nipple in probably the fourth intercostal space right here, this is a good anterior mid-axillary line. So I'd probably go right here and I would mark that on my patient.
Excellent. So the triangle of safety, those borders are basically the anterior, the pec muscle on the anterior side, the lat muscle on the posterior side, and then you don't want to go below the fifth intercostal space.
Correct.
Right?
And it's also a space that doesn't have typically a lot of subcutaneous tissue, so you're able to get in pretty easily in this space as well.
Awesome.
Now, I know we can't also demonstrate with this mannequin right here, but the patient positioning is also going to be key. If you can get their arm above their head, it'll help you expose that area better, and will also allow you to put the patient in a semi-Fowler's position sitting up. This is really helpful, especially if they have that pneumo to accumulate right where you're going to put that needle in.
Mm-hmm. Excellent. All right, so what's the step one? What's the first step?
So after we have our patient positioned and we want to then mark our site, what I'll typically do is actually utilize not a marking pen, but a syringe.
Okay.
So
how do you do that?
If you don't have it, typically don't have them in the kits, but you can take any 10cc syringe. And what I'll then do is you're essentially doing a little bit of a hickey on the patient. And once you find your spot, what you can then do is then put the syringe down on it, and then you will hold suction on there. What you're doing is essentially making a mark that will stay there despite you dressing it, cleaning it later on. It's not going to wash off. And it's something that I really like to do for my patients so I can always see where I'm going to be going.
Very cool. Now, before we stick the patient, do you have any tips or tricks on what medications you give them to keep them calm and out of pain, since you just mentioned that?
Yeah, so once I mark the site, typically I'll only use lidocaine.
Okay.
Sometimes folks will use other things like a little bit of Versed to help calm down patients. But if you properly anesthetize patients with a little sub-Q wheel around the periosteum of the
Mhm.
superior inferior rib, and then through the tract to the visceral pleura.
Yeah.
These patients usually tolerate it super well, especially for something like a pigtail.
Yeah, it's much smaller than your big surgical chest tubes for sure.
Absolutely.
All right, so walk us through the next step.
So what we'll then do is you can select a needle size based on the habitus of the patient. Hopefully for this patient, we can get away with the smaller needle. And what I'll also typically do as well, this is one of my little tricks as well, is if you're going to be doing something, say a pneumothorax, and you want to know when you're actually in the chest cavity, I will then get a little bit of saline that I just have already here in the kit, and I'll put that already in my syringe. And the reason that I do this is I can then see bubbling when I actually get into the chest cavity, and I have a positive sign saying I'm in the right spot, and I can then advance my wire in.
Awesome. Okay.
So can then do, I know my spot isn't showing up well here, but again, in the anterior mid-axillary line, going over the top portion of the inferior rib, so we avoid that neurovascular bundle. So we can go right here. And again, as we're going in, we're going to be pulling back to make sure that we will get air once we get in. And there we go. So I can see I have bubbling, which if you guys can see it on the side shot, which means I'm in the right spot. So I'm going to then remove my syringe. I now have the needle that's going to be in the chest wall cavity, and then we can introduce our guide wire. Here.
Now, how far does the guide wire need to go in?
So it doesn't need to go in that far. I probably put it in about like 20-ish centimeters. So this is going to be a lot of extra length that we're going to have. But we're going to need this so we can then actually feed the pigtail over it.
Got it.
So at this point, now we have the guide wire that's going to be in the chest cavity. I can now remove my needle.
There's a little sharps thing.
Thank you. And then just like your typical Sellinger technique, we're going to then nick the skin so we can then get our dilator in. And you don't want to make the nick too big. You just got to anticipate that this is going to be able to fit the size of the pigtail through, okay? And then we're going to have our dilator. And the thing I'll caution folks with this is, and I'm sure you've probably heard or seen this before, is that when you're introducing something like a dilator or a trocar into a chest cavity, you can sometimes, if you're not careful, shove that into mediastinal structures.
That really highlights the importance of being in the right spot when you start, right?
Absolutely. And usually I'll do a little bit of a cephalad approach with my dilator and also inserting the chest tube itself, just so I'm avoiding the mediastinal structures.
Now I'm noticing you're doing a little bit of a little wiggle of the wire there. Tell us about that.
So every time that you should be doing a Sellinger technique, I'll always make sure that the wire is free flowing to ensure that it's not getting kinked anywhere or if we came out of the wrong spot. Or excuse me, if we came out of the correct spot. So just doing a little bit of a wiggle, and I go in as I dilate, I'm also doing a twisting motion just to make sure that we break up all that subcutaneous tissue and the connective tissue so we can then get the pigtail in. And if you notice too, I'm not using the whole dilator. I got through down to the chest cavity and into, let's say, the pneumothorax in this patient.
And no deeper than that.
Right. And you're going to definitely, when you place these, you feel that give. That means you don't need to dilate any further. Okay. So now once we have that, we have a dilated tract, we can then advance our pigtail onto our guide wire. And so just like we did with the dilator, we want to make sure. So see, I have enough of my wire sticking out so I can actually get and control the wire. Like this. We want to make sure that there's still, it's a plastic trocar, but we want to ensure that we don't send the whole trocar into the chest wall and toward the mediastinum. So once I get in a little bit and I'm actually into the chest wall, what I'll do is I'll hold the trocar and the guide wire all as one unison. I'll just advance the pigtail in.
Okay.
And just based on this patient and the markings, we don't need to advance the pigtail all the way in. It can likely go to the black marks that we have on the side, and I'll usually do about halfway, just about right to there. And notice that the trocar has stayed in the same three-dimensional space the entire time. It is not advanced further, so I'm not trying to lance any medial sinus.
Now, give us a tip as to how to hold that hand, because I see a lot of people, they just kind of free-handed and
Mhm.
you find both hands are moving together. What's your tip there?
So what I'll typically do is I'll brace the trocar with my index and my middle finger, and then I'll press my thumb with the wire against it along my index finger.
Okay.
So this is one solid unit that I can then pull out all in unison, and it's going to stay
Very
intact.
nice. Excellent. I also noticed you had your arm up against your body, and so as you're advancing that catheter, your left arm wasn't moving with it. Great.
And that also ensures that if you get into the chest wall and all of a sudden gives, you're not going to be lancing those mediastinal structures.
Right.
And now once you have that set up, you should have the pigtail in the proper space in the chest cavity. And what we can then do is we can then attach the connection to the pleurax, which can then go to the water seal. And then you can secure it with, and I'll typically use something like a 2.0 or a 1.0 type of silk around the site where it goes into the chest wall. That will not only secure the possibly larger nick I made in the skin, but it'll also prevent it from coming in or out.
Yeah. So do you put any gauze around it? Do you put any Vaseline gauze? What do you do?
So usually what I'll just do is put some simple dry sterile gauze, and I'll use a large Tegaderm.
Large Tegaderm.
Yeah, to put over that. And that has always been adequate for me.
Yeah, fantastic. And then this end is going to be connected down to your Pleurovac, which I guess you'll keep on suction for the first, 24 hours at least, usually. All right. Any other tips or tricks that you can share with us about this procedure?
No, I think for doing especially pigtails, really doing a good setup and also anesthetizing the patient will pay dividends.
Yeah.
Making sure that you're setting yourself up for success, you have all your equipment, and you do a very good job with the local anesthetic. It's going to ensure that patients tolerate this super well. And I've even done this with just pediatric patients only utilizing local lidocaine.
Wow.